Hi, Linda. Just wanted to check you could hear me.
Hey, Barbara. Yes, we can.
Perfect. Cool. I'll mute so I don't cause some drama with dogs or children or something going on in the background.
Hi, Diarrheal. Would you like to test your mic and your video before we start?
Hi, everyone. So can you hear me?
Yes, we can hear you.
This is David from WHO in Geneva.
David, we have background envy. That's looking very lovely behind you.
Perfect. Okay. I was about to. I wasn't sure which one I was using, but I have options.
Looks very nice.
Let me
looks very Swiss.
I'll go more formal.
Oh, yes. Very good. Yes.
Thank you very much. I think we can begin. It's 2 o'clock, so just so we keep time. So, ladies and gentlemen, good afternoon, and welcome to our webinar on climate change and public health. On behalf of the ICPAC director, who unfortunately could not make it today, I'd like to extend his welcome to all of you as well. So this is a part of a series of conversations by ICPAC that we are having that are aimed at increasing knowledge and raising awareness on climate change in the region. So if you missed any of our webinars before, you feel free to check our YouTube page. Today's webinar is also streaming live right now on YouTube and will be made available later on our YouTube page. So for today's program, we have a very distinguished panel, and our program will begin with Dr. Dunya from the Ethiopian Public Health Institute, who will give us an overview of what the region has been experiencing so far, particularly what the key climate change issues are related to public health. Dr. Dunya is currently representing the region in the ongoing IPCC assessment. And after him, we will have Dr. Giffecko from the Kenya Medical Research Institute, KEMRI, and he'll enlighten us on the threats that we can expect in the future in the context of a changing climate and public health. Dr. Giffecko is one of our region's leading experts on climate change and health. And after him, we will hear from Professor Evans from the University of Leeds, who through a project in the region called High Crystal has been able to demonstrate how climate change science can be integrated into public health policy in the region. And then finally, we'll hear from Dr. Diarrheal, who heads the Climate Change and Health Unit at the World Health Organization, and who's done a lot of groundbreaking work globally on climate change and health issues. And he'll be talking about what we can do to protect public health from a policy perspective, and in particular, what lessons we can learn from the ongoing COVID-19 pandemic. So feel free to use the Q&A section at the bottom of your screen for any relevant questions during any of the presentations, and we'll respond to them through the panel will respond to them at the end of all the presentations. My name is Linda Ogalo from IGAD Climate Prediction and Application Center, ICPAC, and I'll be your moderator for today. And without further ado, let me welcome our first panelist, Dr. Dunya Gameda. Dr. Dunya, you can go ahead and unmute yourself and share your screen. Dunya, please unmute yourself. You're speaking, but your mic is on mute.
Thank you very much for the introduction. This afternoon, I'm going to talk to you about past and the present climatic impacts on public health, key issues arising from the ongoing IPCC assessment. So if you can see my screen, I'm working for Ethiopian Public Health Institute as researcher. I think the screen is not moving.
We can see your screen.
Yeah, but I can't move the slides. I don't know what is happening.
You may use your mouse.
Okay. Thank you. Thank you. This is the model that is that I have used from assessment report number 5 for IPCC. I have a good resource person in this team. Andrew was in this team, maybe, I don't know. In this slide, as you can see, the impacts of climate can be categorized into 3 key components. The first one is the direct impact, and the 2 other impacts are natural mediated effects and human mediated effects. Moving to what are one of the direct impacts of climate on health is that the disaster. As we can see, in the from 1964 to 1993, many disasters have happened globally. So the disaster, and as warming is increasing, the disaster, frequency of disaster, and number of people affected are also increased during that period. This is one of the articles from 1997. The second one is impact of climate change on global malaria distribution. As you can see from the left side of the first panel, the observed impacts of climate change on malaria. There is a distribution, high burden of malaria in the tropical and the subtropical areas. From various models, we can see C, D, E, and F, G. We can see there is a predominance of malaria in the tropical and the subtropical areas. If one of my arrows is visible on the panel A, for East Africa, from 2020s, 2050s, and 2080s, there is an increase in additional populations at risk of malaria. And also on panel B, where additional person months at risk of malaria is also increasing, according to the simulation for the sub-region. Coming to another important climate-sensitive disease, that is cholera. As we can see from this map, these 3 maps, the distribution of cholera is almost all occurring, is endemic in most parts of Africa, but it is burden is varying in the sub-regions, and also in each country there is also variability. This is when we see country-specific issues, like if you take Nigeria and Democratic Republic of Congo, the incidence of cholera is concentrated in certain areas. So if we prioritize high-risk areas, this could substantially increase the efficiency of cholera control programs. The other important issue about cholera is there is a shift of cholera to eastern part of Africa. In the sub-region, cholera is predominant, especially in Somalia, Kenya, Tanzania, Malawi, Zambia, Mozambique. There is cholera is associated with El Nino occurrence, especially with increased rainfall. Still, there are areas with high incidence of cholera with decreased rainfall, showing that there is a complex relationship between cholera and El Nino. When we moved our service to the special report that came during 2018, which is the base knowledge for the write-up of assessment report number 6 that, as already mentioned by moderator, I'm representing the region on health. This is the how closer are we to the 1.5 degrees Celsius warming. Human-induced warming reached approximately 1 degree Celsius above pre-industrial levels in 2017. From this graph, you can see how the current warming trend looks like. So human-induced warming reached this level with this range, and the warming is greater than the global average. This is already experienced in some of the areas. From this special report, as shown in chapter 1, human-induced warming for different parts of the globe is, you can see from this graph, the East Africa is almost reaching about around 0.75, if I'm correct. And in northern part of Africa, that 1.5 degrees Celsius is already reached. So when we see the impact of climate change in the present situation, you can see the vector-borne diseases are representing the high share of the burden. And from this, we can understand also there are adaptation currently going on. When we see the deep colored one in this band, we can see potential for adaptation, especially when we move to the 1.5 degrees Celsius. Still for vector-borne disease, there is a possibility to have adaptation. But when we come to undernutrition, this is also one of the important health issues in East Africa. There is a risk level with high adaptation. So when we move to the 4 degrees Celsius, the problem is the undernutrition is becoming problematic. And I can assure you that if you act as soon as possible within the era of continued climate change, I think we can bring changes to most of the climate sensitive diseases. As a summary, in 1 minute, East Africa is at high risk of climate sensitive diseases such as malaria and cholera. I'm not disregarding other climate sensitive diseases. These are some of the climate sensitive issues which are burdening East Africa. They are almost always high burden, and there is high variability of cholera burden among countries, and still there is also variability within a country. So creating a data set for disease and assessing its relationship with climate change and the variability is recommended to design effective adaptation approach. Maybe the last but not least, strengthening the surveillance and the modeling is believed to be help us identify priority zones and allocating resources where it is highly demanding and advancing our interventions. This is what I have for you in my presentation. Thank you for your attention.
Thank you very much, Adunya, for that interesting presentation. You've said that we've seen an increase in population at risk of malaria, and also the point that you've made about the threefold increase in cholera is actually quite interesting. If you have any questions for Adunya, please put them in the Q&A or the comment section. We will get to it at the end of the presentation. Next, we will welcome Dr. Andrew Giffecko from KEMRI. He'll be giving us a presentation on what we can expect in the future. So we'll share his presentation in a few minutes. Andrew, you can unmute yourself. Andrew, do we have you? We had him a few minutes ago. Did we lose Andrew? Andrew, please just hit unmute. Our communications team will share your presentation right now, but you can hit unmute. And yes. And then just unmute yourself.
Okay.
Yes, we can hear you now.
You can hear me now. Okay. So, okay, you gonna load the talk?
Yes. Marta, please share the presentation.
Pardon?
We're loading your presentation,
Okay.
but
Oh,
you can
Linda,
go ahead.
Linda,
Yes, Andrew.
okay, apologies. I think my device made some auto corrections. So some words are very strange, like monitoring was turned into non-smoking. So we
Sharing
all right.
soon.
Oh my God. Okay, so thank you very much, Linda, for this invitation and all the audience. I've been working on this matter of climate change for a long time, since 1998 in IPCC. And we have a climate and human health research unit at KEMRI in Kisumu. So most of what I'm about to say has just been covered in by the previous speaker, but we are now going to focus more into the future, what is going on. Now, the major driver of this is climate change. So we want to see what climate change is doing and what it's going to do in the near future. So the observations that have been made recently is a high rate of increase in the mean temperatures, particularly in May to June. That's the main rain season, and that's the main transmission season for these vector-borne and waterborne diseases. Now, all those diseases, or rather the vectors and the pathogens, are climate sensitive and particularly temperature sensitive. So the higher the temperatures, particularly during that period, the higher the rate of transmission. Now, we also observed a high trend in the maximum and minimum temperatures. I monitored temperatures in around Kisumu, and in the last few months, we've seen quite a dramatic increase in the minimum temperatures at night. Whereas they used to be around 1918, now we are seeing about 22, 23. It only gets to 1918 early in the morning, around 5 or 6. For the rest of the night, we're in the 20s. That's very unusual. So that will support the vectors. Now, we have seen an increase in extreme temperatures. Before, the extreme temperatures around this area used to be about 33, 34. But once in a while, we have seen 36, 37. And studies have shown that this is a general trend in the region. We have seen no clear change in the rainfall trends. Some places may have had extreme rains, but generally the totals don't seem to have a particular trend. There are some observations that during the long rains, there's a decrease in the total rainfall. And the shorter rains are receiving heavier rainfall. But on average, the trend is not very clear. there's then increase in a frequency of extreme events such as flooding. Of course, flooding, if it's in some cases will drive vector-borne diseases, and also water and foodborne diseases. Okay. Now, the diseases we're concerned with are basically the vector-borne diseases, such as malaria, which is a very big one. Rift Valley fever, it's another big one, and is expanding its range. Dengue is becoming more common, and it's terrible because sometimes it's misdiagnosed as malaria. We have seen some outbreaks of chikungunya, and these diseases are driven by temperatures. The mosquitoes take a much shorter time to develop during high temperatures. They also affect the virus in a mosquito. And this effect is actually exponential. A very minor change in external temperature can significantly reduce the time it takes the virus to develop in a mosquito. So that intensifies transmission. The same thing with the parasites, such as malaria parasites. The hotter it is, the shorter they take to develop in mosquitoes. And therefore, each mosquitoes can transmit to many more people. Then we have the waterborne diseases, the big one being cholera, of course. It was in the 80s, maybe even 70s, it was confined to the Lake Victoria region. We did some work in the early 20s, monitoring cholera around the lake and in the adjacent highlands, the Western Kenya highlands. And we didn't find any cases of cholera in the highlands. But now, recent reports indicate that the cholera has moved up the highlands, and more interesting, it's moved up to central Kenya, where cholera was basically an unknown. Now, it's not very clear whether this is because of just human movement or the conditions have changed to the extent that now there's cholera. This one is a bit complicated, but the disease is definitely shifting around. Then we have Shigella, a terrible disease. This is a diarrheal disease. E. coli, those are waterborne diseases. Amoebiasis, Giardia, and another one which became notable during the HIV outbreaks, Cryptosporidium. It's a waterborne disease, and it causes serious disease to people who are immunocompromised. So with HIV, we saw a lot of Cryptosporidium, but it's a waterborne disease, so it's fecal disease, and it will get into public water supplies because of flooding. So, as we said, there are increasing flooding, so that's a threat. So, the threats from climate change involve continued increase in temperatures. Of course, those who support all these vector-borne diseases. It will also support some diseases like meningitis, which are airborne diseases, asthma, common colds because of pollen. Then we have an increase in, it also cause what we now call isotherm shift. In other words, it gets warmer in the highlands, as would be noticed in Kenya, Ethiopia, Burundi, Tanzania. So the highlands become better, warmer, and therefore the mosquitoes will establish themselves, and the disease will shift upwards. So that one is observed. there's an increase in extreme precipitation. In Kenya, people will know about Pokot, terrible floods in a lake shore area. The lake has gone up by 1 meter, and the lake shores are being flooded. So although there seems to be no trend in the total rainfall, things such as the recent increase in the lake level are not just Lake Victoria. You have Nakuru, Bogoria, and other, possibly Turkana. That's an indication that something is going on. So this trend will support disease transmission. Now, intervention related threats. You will know that the whole region has a common intervention for malaria. They have mass distribution of insecticide-treated bed nets. Now, when these insecticide-treated nets were issued, they were very effective because mosquitoes were completely susceptible to the insecticide. But in recent years, we have carried out studies in Western Kenya and elsewhere, this East Africa generally, and the mosquitoes have become resistant to pyrethroids. And they're not that effective now. The other thing that's going on is that the mosquitoes, these things are very smart. Never underrate these mosquitoes. They're changing their behavior. Because people sleep after 9 o'clock, and it's too dangerous to bite after 9, they are now biting, not all of them, but some of them, and an increasing number is biting before 9. In places like Ethiopia, you have several vectors that are biting people outside. Pharaohensis, these are mosquito species, and they are now vectors. They don't go inside the houses, but they wait for people before they go inside the houses. They bite and transmit. So the other issue apart from mosquitoes is that we know, like in the 80s, actually from late 70s, the malaria parasites became resistant to chloroquine and another drug called sulfadoxine pyrimethamine, SP. Fortunately, in the early 2000s, we got the artemisinin combination therapy, which was developed from a Chinese drug. It's still very good, but in some parts of Southeast Asia, there is some evidence of resistance. And that can be expected to spread into a region. So that's another threat. So the interventions may fail while the transmission is increasing, or the transmission conditions are getting better. So that's really a very serious problem. Now, we don't have vaccines yet. Not good enough. They are there, but they have an efficacy of about 40%. And you need several doses, I think 3 to 4 doses to get it. And only 40% of the people will be protected. They're working on this. Hopefully, the efficacy will improve and more people will be protected. Now, we don't have, now you can see there is a spelling mistake in that sentence. I don't know what it means. We don't have, we have vaccines for Rift Valley fever, but for cattle, for livestock. That vaccine has not been approved for human use. We don't have an effective vaccine for dengue, and dengue is increasing. Now, Chikungunya virus is worrisome because it seems to be mutating. Before it was transmitted by local mosquitoes, Anopheles gambiae, Anopheles finescens. But we then got an Asian mosquito called an Asian tiger mosquito, Anopheles albopictus. When that virus entered this vector, it seems to have become more virulent. So that's worrisome because chikungunya wasn't that serious. You got your pains, you had a fever, but now it can make you very sick. So that's something to worry about, and it's spreading quite fast. So what we do, we need to undertake very active surveillance of vectors, check the resistance, check the virus, see if they're becoming more virulent. For instance, dengue has 4 viruses, type 1, type 2, type 3, type 4. If you get type 1, you get away with it. If you get more than one, the disease becomes what is called hemorrhagic. You bleed everywhere. And that kills. So the more isotypes we have, the more dangerous it is. So we have to keep monitoring and trying to find out how many strains we have. Of course, we have to keep on looking at how sensitive the malaria parasites are to current medication. So then we need, now this is what we are saying, we don't mean non-smoking. It is active monitoring of the efficacy of these therapies. Now we need to develop sustainable adaptation. That is, we are getting to the conclusion of this. We should not just wait and watch. We are arguing that our current institutions will become highly vulnerable. We saw this in 1997, 98, when we have multiple and complex disasters. We had Rift Valley fever, we had cholera, we had malaria. Those are the big ones, the super diseases. But you also had the little ones in the background. One country actually ran out of medicines in the South African region. They didn't have enough medicines to treat malaria, so people just died. Then others, you have drugs, but they're not very effective. So we need to have a very, very active system to monitor. And another thing is to be able to focus these disease extremes. We in Kemri have developed a system for focusing malaria epidemics in the Western Kenya Highlands. There is need to develop such models of early warning systems for cholera so that we are prepared, we are not caught unaware. So it's up to our governments to support research in this area of adaptation. Thank you very much.
Thank you, Dr. Terry. That was a very interesting presentation, especially linking the shift in diseases to an increase in temperature that is being projected to increase, and an increase in extreme rainfall that the climate scientists have said will continue in frequency. And so you also talked about the mutation of mosquitoes. I thought that was very interesting, particularly the malaria mosquitoes and the dengue mosquitoes. And you touched on in your slides some of the issues that are not talked about so much in the climate change sector on malnutrition. That was on your slide as well, and also the diseases that come as a result of pollution. So that was a very interesting presentation. And if you have any questions for Dr. Giffecko, please, again, put them in the Q&A and the comment. We'll come back to him. And I'd like to now welcome Barbara from the High Crystal Project, who's done very interesting work in Kisumu as well. So she can tell us what they learned and how they then took that took the research part and began to integrate it into policy. Welcome, Barbara.
Thanks so much, Linda. Can you see my screen?
Yes, I can.
Perfect. Thank you so much. Thank you very much for giving me this opportunity. So I just want to go from the high-level impacts that we've been talking about. One of the big challenges, of course, is what do ordinary policymakers and people working on the sort of normal levels of local government do about this. So I wanted to just share some results from High Crystal, which is a very large project. I think we've interacted with many of you in the past, and I just want to give credit here to a huge number of people who've contributed to this work that I'm going to present here. Oh, sorry, my slide is not progressing. Let me just sort that out. So in the High Crystal project, we had a large piece of work that was looking at generating new understanding of the East African climate, and many of you have touched on these findings in the past. But the key point I want to make here is overall in East Africa, as we all know, the exact change in the rainfall pattern is uncertain. But one thing we're very sure about is that the incidence of intense rainfall will increase, and the peak intensity of rainfall will also increase. So as Andrew said, we can already see the effects of that in terms of these increasing incidents of fairly catastrophic flooding. So one of the things we know, even though there's still uncertainty in the models, is that we really have to think about improving resilience to extremes. And in infrastructure, there's quite a challenge because the planning horizons are quite long and quite out of step, really. They're too short for planning to the climate horizon, and they're too long for sort of immediate responsiveness. So one of the things we've been talking about in one part of the High Crystal project is working with local government in Kampala and Kisumu to think about how we can reimagine and re-understand urban sanitation in the context of climate change. So the link here is, as I say, we know that climate is going to change, and therefore we know that rainfall intensity will increase. We know that that will result in increased incidence of serious flooding in urban areas, and that flooding results in specific damage to public health infrastructure. So on this slide here, these are all very familiar things that you will have seen. So, you know, when we get these intense rainfall, we see damage to sanitation structures. We see people investing huge amounts of their own money to try and protect their toilets and their houses from flooding. We see people emptying fecal waste directly into the flood waters, either formally or informally, well, either in a planned way or an unplanned way. We can see in the aftermath that we get this serious kind of contamination of the environment, and that links very much to the data that we saw in the first presentation about upticks in cholera epidemics. And we know that it becomes very difficult to manage the sanitation system, particularly where, as we often have in East Africa, we're dependent on trucking and sort of road or physical access to sanitation systems. And all of that obviously has high levels of potential negative health impact. Now, in this project, we tried to estimate the scale of that impact, because we're trying to create a link between making investments in improving sanitation infrastructure and climate resilience, partly as a way to help local governments to access climate funding. So in the two cities where we worked, we did a range of activities. We worked with communities to understand how flooding actually happens on the ground, how people respond and behave in flood events, and what the experience of health impacts is. So what do people understand happens when, you know, how frequent are increasing incidents of acute watery diarrhea, possibly cholera, enteric infections generally. Also, as part of High Crystal, we did a lot of work trying to simplify some of the climate science so that we could use it to talk to local government and communities. So some of you will have seen our climate narratives that really try and articulate quite clearly how confident we are in this likely increase in intensity of rainfall events. And then we took these future rainfall patterns and we used those to generate downscaled future rainfall events, which we could then use to drive hydraulic flood mapping. So we could really start to look at what flooding is going to look like in the future under future climate conditions. This is a relief map of Kampala. Also, we hunted and found some of the really amazing data that already exists in both Kampala and Kisumu. So I'm just going to talk about Kampala as the example here. This is some fantastic data that KCCA have. They've been mapping their sanitation systems for a long time. So these are maps which tell us really where all of the latrines and toilets are in Kampala. And obviously what we're then able to do is overlay data that we have on sanitation systems with the flood data that we have. So here are some new maps that we've produced that really kind of show us where are the concentrations of poor quality latrines or high quality latrines or badly managed latrines or well managed latrines and intense flooding. Over here we've pulled out under a typical future rainfall event all of the latrines that might be flooded. And then what we're able to do, in this case, we've just taken Makindi, which is just one of the subcatchments, just to present the data, make it more simple to understand. We looked at what is the likely health impact of this overlay of increased flooding and the existing types of sanitation that we have. So we asked the question, how do these floods impact on the amount of fecal matter which is in the environment? And these are some results. Each one of these lines on this curve, this is a storm event, a typical future storm event over the first 6 hours. And in each of these lines, we're looking at one subcatchment of Makindi, and we're looking at the total amount of fecal waste that we estimate is going to be washed out into the environment. And what you can see is that this first spike here is actually not fecal waste that's in the toilets. This is all the fecal waste which is already in the drainage networks, because many toilets are either directly connected to the drains or the contents are regularly dumped into the drains. And then we can say, well, what happens if we could organize ourselves so that all the latrines were emptied before the major flood event? So, I mean, this is a notional idea of what would happen if all the latrines were emptied the day before the flood was coming. And ironically, what happens is we see a big increase in the amount of fecal waste in the environment. And that's because we know that a lot of people are still emptying their latrines into open drainage nearby to their houses or just beside their houses. So a more interesting question is, what if we could formalize and regulate latrine emptying and manage to make sure the latrines are emptied well before the floods arrive? And here at last we can see a fairly significant reduction in the total amount of fecal waste that enters the environment. Now this matters because it allows us to also understand what would be the probable risk that people experience. In a flood, we now know how people respond, where they go, whether they stay in their homes, whether they leave, and we can start to estimate their levels of exposure to fecally contaminated water. So this is taking all of that fecal waste data over the same 6-hour period and looking at concentrations of fecal bacteria and viruses and protozoa in floodwaters. And then we know quite a lot about how people can be exposed to those floodwaters. Some of you will have heard of the Sanapath project, for example, that helps us to estimate that. So taking all of that data, we're able to make a mapping essentially of what we think is the scale of the health risk to communities in each part of the basin. So that in this map here, this is the whole of Makindi, this is the lake down here. We can see, strangely actually, that the darkest colours, so the highest incidence of health risk, is actually at the upstream end of the basin, which is very counterintuitive. We were expecting to see the big impacts down here, but actually at the lower end you get quite a lot of dilution. So down here we're seeing much more sort of damage and psychosocial kind of stresses. Up at the top we're seeing these concentrations of infectious enteric disease and particularly fecal-oral diseases. And over here we can use QMRA modelling to turn those into probable levels of disease. Now all of these numbers are quite, they're based on models, and we do ground truth them by working with communities. But what it enables us to do is to get a feel for the potential impact of investing in improving the resilience of these systems. Overall, this is really important because people themselves have very little agency in managing flood risk. So we're very used to saying, well, people should do something. They should make themselves more resilient. But these type of interventions to manage fecal waste in the city are very much something that local government has to play a role. And we're really hoping that we can use this data to enable local government to make the case that improving the resilience and the active management of the sanitation system and the drainage system has such strong positive health benefits that you can fold it into any climate resilient planning that you might make at the city level. And crucially, a lot of what's needed is this active management. So we're really trying to make the case that really good, well-funded operational budgets for local government are a key part of making critical public health infrastructure resilient. So I'm going to stop sharing. I hope that was just a quick rocket fast tour through our work. And I'm very happy to take some questions at the end of the session. Thanks, Linda, back to you.
Thanks so much, Barbara. If you have any questions for Barbara, please put them in the Q&A and or in the chat box. That was a very informative presentation. Usually as scientists, we get a lot of data, but we don't get a lot of links on how then the users of the climate information can then begin to take this information and then make practical choices in order to help the local communities. So it's good to see how working with the Department of Sanitation and how that can then impact public health in the long run. So next, we'll like to welcome Dr. Diarmid, who can maybe let us know what the way forward is, because some of the presentations have been a bit bleak. If we look at the changing evolution of mosquitoes and resistance to drugs and increasing temperatures, increasing cases of different diseases on top of what we're already dealing with the pandemic. So what can we do in terms of policy as a region, as member states, to then prepare us for what is to come? And what can we learn from what we're experiencing now? What are some of the key lessons that we can learn? Welcome, Dr. Diarmid.
Well, thank you very much. Thank you very much for the invitation to speak. And if you can see my slides, if you can see my title slide, then I don't think I've exactly responded to your invitation to be less bleak. The slide that should be showing is an illustration of what happens when you have a global pandemic in the middle of an ongoing climate crisis. Basically, the effects of, effectively multiply. The slide here is taken from the US, where wildfires were sweeping through the western United States, partly probably driven by high temperatures and drying in that part of the world, at the same time as we were giving people instructions on how they should behave in order to protect themselves from the COVID-19 pandemic. So I won't completely avoid the bleakness of the situation, but certainly to take the invitation to say what we think we can do about this at a national or at a global policy level. And first off, thanks very much to the other presenters for providing the information on the risks that are the health risks that are particularly faced in East Africa from climate change, but also some of the sort of the detailed information on how that affects communities and what can be done at the community level. So I was invited to speak a little bit about what we have learned from COVID-19, and I think some of the parallels, some of the instructions for how we protect health in the face of climate change. One of the, I think there are a few lessons. Some of them I think have been quite well summed up by the climate protesters, the young climate protesters who are mobilizing around the world to try and pressure leaders to take action on climate change. One of them is to treat a crisis like a crisis. We have known the evidence on the effects of what is driving climate change, the effects of climate change on health in general terms for a very long time now. It's very nice to see Andrew on the call. You know, I've known Andrew for a long time, and one of the people who's been researching for the longest on the impacts of climate change on health. And one of the things that we have learned from COVID-19 that we should have already been doing on climate change was basically to follow the evidence that we know that we knew very quickly. In fact, within the first couple of weeks of what was happening with COVID-19, we knew what the pathogen was. We knew how it was transmitted. We knew in general terms what it would take to protect ourselves. And to a great extent, countries around the world have followed the evidence and have and put into place protective measures. And those that have done the best are the ones that have stuck most closely to the evidence, and that also have had clear leadership, strong public health communication. So those are exactly the kinds of lessons that we should have already been applying to climate change. And it's never too late. We still have that opportunity to respond in the way that we should respond. Another of the lessons that we have taken from COVID-19 is the importance of protecting the most vulnerable. Again, it's very clear with COVID which parts of the population are most vulnerable, which age groups in particular are most vulnerable, and you can see that in the delivery of vaccines in those countries that do have vaccines, that they're very much targeted on particular parts of the population because that vulnerability was recognized and characterized quite early. And another message, again, from COVID-19 is the importance of global solidarity. Again, we're seeing that, I would say, not in a particularly good way at the moment with the distribution of vaccines, where we have an extremely inequitable situation in terms of who is getting the vaccines. It's basically those countries that can afford them and that were able to buy up supply, perhaps even over contracting vaccines. Whereas those populations, including those in low and middle income countries, including much of your region, still have no or very limited supply of vaccines. That's not good for anybody. And global solidarity and international cooperation is as relevant to vaccine distribution or the response to the COVID pandemic as it is to the climate crisis. And I think one of the other general lessons that we're taking from this is that you have to update your understanding as you go along, and the faster you do it, the better. One of the examples from COVID-19 is that the countries, the populations that we thought would be most vulnerable, would be most ill-prepared to deal with a pandemic of the kind of COVID-19, that is not necessarily how it panned out. Famously, not long before the pandemic hit, there was an index published of countries' preparedness for a pandemic, which ranked the European countries, ranked the US as the best prepared to deal with the pandemic. And that is very much not how it has panned out. And that just underlines that it's not all about money. It's also about the strength of your public health system. It's also about the clarity of leadership and the extent to which communities can be mobilized in order to take the measures that should be taken. And again, that is something a lesson that we think we can apply to the climate crisis. So moving from those sort of general lessons about the parallels between COVID-19 and climate change, one of the things that we have been doing at WHO in response to COVID-19 from quite early on in the pandemic, so from May of last year, we published a manifesto on a healthy and green recovery from COVID-19, because although most of our attention and the attention of national governments from around the world was focused on putting into place public health measures, on locking down economies and so on to stop transmission, we also saw that the decisions that were going to be taken in order to prop up economies or to recover from the COVID-19 pandemic, if we got them wrong, would be really bad for public health and for the environment over the longer term. So we published what we called a manifesto for a healthy recovery from COVID-19, but an emphasis also on environmental protection as well, with 6 prescriptions that you can see on the right. So the importance of protecting nature, that's including to reduce the risk of future pandemics, because there is some evidence that, there is evidence that all of the pandemics that we've suffered from in past decades have come from the natural environment, and some indication that that's due to environmental degradation, accelerating their emergence from the natural environment. The importance of ensuring basic services, so water and sanitation, energy supply, and so on. So the kinds of things that we're just hearing on the presentation on urban sanitation. One of the lessons that we see is that we have a real problem with climate vulnerability in populations that don't have things like basic water and sanitation or decent provision of public health services and functioning healthcare facilities and so on. So we want to make sure that as investments come in to drive the recovery from COVID-19, that they invest in things like that. The importance of healthy and sustainable food systems. We heard earlier a little about the effects of climate change on food security, particularly in East Africa. You'll also be aware, and it is also an issue in your part of the world, that the world suffers about as much ill health now from overweight and obesity and unhealthy food systems, food and nutrition systems and practices as it does from undernutrition. And that's also a major driver of carbon emissions and therefore the climate crisis. So there is an importance in sustaining, in supporting sustainable and healthy food systems. You'll also be aware that most of the global population now lives in cities, again, a trend that's important in your region. So it's important to invest in cities that are sustainable, they're livable, that enable walking and cycling, that reduce air pollution, that are safe and secure, and so on. And the final one is that we prescribed is to stop subsidizing pollution. At the moment, the world spends a lot of direct cash in subsidizing the fossil fuel industry, which is also the main driver of air pollution, which kills about 7 million people a year around the world. And we effectively subsidize them even more because the health impacts of those unsustainable and unhealthy energy systems are massive. They, as I mentioned, those 7 million deaths a year from air pollution around the world are effectively a subsidy that we allow the fossil fuel industry or polluting energy to have, because they're not paying the costs to ill health of populations. So those are the high-level messages that we were sending about the direction of travel that we thought needed to happen in the recovery from COVID-19. And then to get on a little bit more specifically to the overall tasks that we see for public health in the face of climate change. So we tend to sum these up from WHO in three tasks. One is in getting behind the drive to reduction in global emissions. We all know that the world is well off track for meeting its commitments to the Paris Agreement. We're more on a trend which is just carrying on increasing emissions. And we think that health not only has to play its part, but actually has some really good arguments for why countries should shift to cleaner energy sources. The reduction in air pollution is just one of them. So we think that health has a critical role to play in decarbonisation. The next, the one that I'll talk about most in the next few minutes, and the one that you've heard most about already, is in protecting health from the full range of climate risks. And you've already had a really good introduction to those: extreme weather events, improved conditions for infectious disease transmission by vectors or by water, and also things like the gradual rise in sea levels, which will make parts of the world uninhabitable and therefore a massive public health catastrophe. And then finally, we have an increased focus on what should actually go in within healthcare facilities as the place where most health services are delivered, and a particular drive to make them resilient to climate risks, to weather extremes and so on, but also to make them sustainable as well. So in many cases, the interventions or the choices we would make about how we would supply water or how we would supply energy, sometimes now it's the environmentally sustainable choice, which is also the cheapest and the best for public health as well. So we have an interest in driving that change. So just briefly, just one slide on the kinds of ways in which health can contribute to that drive to reduced emissions. It's been estimated by the International Monetary Fund, the IMF, that many countries are now putting a price on carbon, putting in place carbon taxes. It's been estimated that if that price on carbon was also set at a level that took into account the public health damages, particularly via air pollution, then you would have a large financial incentive to shift to greener energy, in a way that you would have significant cuts in greenhouse gas emissions and also in air pollution, and you would generate revenues that could be invested in health services and so on. And a very large part of a justification, the economic, the valuation, the justification for a price on carbon is actually the avoided damages to health, it's the health benefits. So we think that's an example of where health can contribute to the arguments for reduced carbon emissions. But the part that I'll talk about just a little bit more in the next few minutes is on the overall approach to improving population resilience to climate risks, whether it's through health facilities, health systems, or in the community as a whole. And the approach that we have adopted to this over the past few years is that we've done a certain amount of work on of the kinds of projects that you're hearing in the last presentation, working with particular countries on particular health impacts or routes through extreme weather events, heat waves, or effects on water and sanitation, vector-borne disease, and so on. And we wanted to sort of generalize that to say, okay, what is the overall approach that countries should adopt if they want to strengthen their resilience to health risks, health system resilience to climate risks as a whole. So we've adopted a systems-based approach. We published an operational framework for building climate resilient health systems in 2015. And that says in the context of a health system, and health system including the outreach to communities, they're continually challenged by shocks like extreme weather events, floods, droughts, and so on, but also long-term stresses. And we have the opportunity to, what we're trying to do is to reduce vulnerability by reducing exposure, protecting people, keeping them out of harm's way, reducing the sensitivity, so that the degree to which when a weather event hits, that actually feeds through into the community. A good example of this is that we know that in populations that have good sanitation systems, the impact of higher temperatures or a flooding event is much lower than in those populations which don't have good sanitation systems. So that's a way in which we can reduce sensitivity, is by providing those essential services, but also by increasing adaptive capacity. So actually taking account of health risks and putting into place specific measures to deal with the risks that come from climate change. And what that does is to put us on it more towards the high end of what you see on the right in terms of the outcome options. So ideally transforming systems so they're actually better than they were before we started considering climate change risks, and avoiding what happens at the bottom, which is where accumulation of climate risks cause a system to collapse. So that's the general systems-based approach that we have taken to this. And we also took the choice to say, well, we don't want to come in and try and reinvent health systems for climate change. Health systems are already in place. They're doing a fantastic job, usually the best job they possibly can, given the resources they have available. Is to say we start with what is already there, and most health systems people will recognize building blocks of health systems around leadership, around finance, around information systems, delivery of basic services. So that's the core, what's at the center of the diagram that you should be seeing. And then what we did was to say, okay, there are additional functions that you need to build onto those to deal with climate risks. So if you already have governance of health systems, well, you also need to think now about reaching out to the other sectors like water and sanitation, food systems, and so on, to take account of climate risks. You already have the investments you make in health workforce. Well, now you also probably need to train people on climate risks as well, and so on around the system. And just to illustrate a few of the ones at which we're concentrating on from WHO, is to point out that additional finance does need to come into health systems to deal with climate risks. At the moment, this is almost entirely neglected from climate finance. There is effectively just about no investment. There's less than 1% of multilateral climate finance from the Green Climate Fund or others actually goes into protecting people's health. So that should change. We also have a particular demand from countries. A lot of ministries of health understand the systems-based approach, but they say, okay, but we're responsible for hospitals, we're responsible for doctors and nurses. So they're particularly interested in knowing what they can do with their infrastructure or with their healthcare facilities. We also know that we need to invest, we have a demand for investing in health workforce as the most important part of any health system. And also, and this is maybe a link to ICPAC, one of the consistent demands that we've always had is for climate-informed surveillance systems. So the kind of work that Andrew does and that we're working with Ethiopia and others to support. So it is really important that we have access to meteorological information in order to build risk mapping and surveillance systems that can support public health programs. We're really happy to work with meteorological agencies on that, but it's also to understand that that's just part of the picture that we're trying to promote in the systems-based approach. Just in the last couple of minutes, I just wanted to point out where we think we are in terms of progress on this issue. We generally see that over the years we've been working on this issue, that the amount of interest, the amount of engagement on this has increased significantly. I mean, when people like Andrew and myself a few years later started working on this issue, there were only really 5 or 10 people around the world who were really engaging on climate change and health. That's changed, and now ministries of health do recognize that it's important, and that there is the same recognition from the climate change side as well. So we see, for example, that in the nationally determined contributions to the Paris Agreement, most countries do mention health. They do say it's important. A large proportion of countries now develop a health adaptation plan and include that within their overall climate change response. The problems that we see are that, for example, countries are not valuing the health gains that would come from low carbon development trajectories. They could quantify them, they could value them. For the most part, they're not. And we also see this deficit in support that actually comes to protecting health from climate change. So it's progress, but there are still big gaps. We also see increased recognition within the climate change discussions as well. So this slide is a slide that's actually from the UK presidency of the Climate Change Convention this year. They will be hosting the COP meeting this year. Along the top are their 5 campaign aims, and along the bottom are the connections that they are already making between health and their campaign aims. And we're working with them on this. And so I won't dwell on this slide, but just to say that there is now a much greater appreciation of the links between health and climate change. And that's partly because many of us have been working on this for a long time, but it's largely this year because of the impact of COVID that everybody is now relating COVID and health to everything they do, including health, including climate change, sorry. And so the final slides are just to point out that the UK presidency has now identified health as one of its flagship priorities, alongside, it's one of the 3 priorities alongside water and infrastructure. So we see it as being sort of at the big table now on the climate change discussions. And they're also planning to launch a series of initiatives to reinforce that priority, on building climate resilient health systems, on reducing emissions from health systems around the world, and in mobilizing the health community as a trusted voice that could advocate for climate action. And just, I think this is the final slide, just to underline the importance of that voice. The trust, the importance of the health community as trusted advocates and trusted partners is second to none. This is a slide, this is public polling from the UK to basically ask people in the street who they trust more from different professions. Doctors and nurses are the single most trusted profession, which just underlines, I think, the importance of linking between climate change and health, and the important role the health community can play in driving action both on mitigation and on adaptation. So I'll stop there and thank you once again for the invitation, and happy to discuss further. Thank you.
Thank you very much for that enlightening presentation. Before we go into the Q&A, if you have any questions you'd like to answer live, please raise your hands. We can allow you to ask the question in person. So thank you very much again, Dr. Dermot, for your enlightening presentation, particularly on how we need to protect the most vulnerable, how we need to update the information we have as we go along, and on the importance of a system-based approach, and in order to strengthen resilience to climate change, and particularly touching on how we need to stop subsidizing air pollution. And I will now open up the floor for any questions. Esther, you can go ahead and unmute yourself and ask your question.
Hi, good evening, everyone. So I'm in Australia, so it's evening now. Thank you to all the panelists. And so I've had the pleasure of working with a couple of you, so it's great to see, to just hear about the presentations. And in particular, Dr. Giffecko, I did have a couple of questions for you. So first, I was wondering, because you did mention that there has been an increase in virulence of the Chikungunya virus. So I was just wondering how much of this, if at all, if there's any evidence that this is attributable to climate change, or if there are other driving factors. And then my other question was, so there's a significant amount of evidence on climate change and malaria risk for Africa, and we have enough of that. And we see that, you know, Aedes is fast becoming the dominant mosquito, and with it, it's coming dengue and chikungunya, but we haven't seen a corresponding increase in research in Africa for these other viruses. So I was just wondering, what are some of the barriers that's limiting research in this area, if at all, or what are some of the research priorities for Africa going forward?
Okay, thank you very much. These are very interesting questions. With regard to the chikungunya virus becoming more virulent, I don't think it has anything to do with climate change as such. You know, there's been a shift in vectors from Asia to Africa, from Asia to Europe, and even viruses like West Nile virus shift was not in the US, but a few years ago it spread to the US. It's not clear how it did that, but some people think it came from Israel, and it's all over the US now. Something to do with climate change, because the conditions were permissible in the US for transmission of this virus. Now, it seems it's chikungunya and Aedes albopictus met together, and some kind of genetic shift happened, and the virus just became more virulent. But as of yet, we don't know how climate could have changed this pathogenicity of the virus. However, albopictus, as you know, dengue, let's say Aedes aegypti is an urban mosquitoes, but albopictus is more rural. So, which means that we can expect more rural transmission of chikungunya and dengue. We don't know what drives albopictus to go rural. It's probably because there's breeding habitat preferences, because in urban centers, it's usually discarded tins and tires and this kind of stuff. So there's a problem that is still being examined. Now, what you've raised is very important about the importance of dengue in Africa. You know, previously, dengue main issue was yellow fever. But over a long time, yellow fever has been controlled using vaccines. It's not a big issue. If we have a very good vaccine, it can be contain the transmission, and transmission is usually limited to urban areas. So people didn't seem to worry too much about diseases that are transmitted by Aedes until dengue invaded Africa, or rather started expanding. And then we had a threat of chikungunya, and who knows what next. So I know of only one or two projects which were funded by the National Health Institutes, because part of it was running in my center, where they did all the surveillance research on the prevalence of the virus at the coast of Kenya and Western Kenya. And surprisingly, the prevalence is quite high in Western Kenya. This is new. we really need to invest in Aedes research, because this is a vector that transmits a whole bunch of viral diseases, and most of them are serious. So there's need to push for investments in this area in terms of research. And worse is that these diseases don't have a cure. Dengue doesn't have a cure. Chikungunya doesn't have a cure, and so forth. So if this disease spread on a large scale like malaria, it would be very problematic. We know of one hospital in northeastern Kenya which was totally paralyzed because all the doctors and nurses had dengue. So there's no way to treat the patient. And that's quite not uncommon in viral diseases. It happened in Sudan with the Lassa fever. It happened with this other one, which was going on in West Africa. So we have to be very careful with viral diseases.
Thank you very much. Next, I think we'll let Barbara answer one question live. You had the question on, you showed the concentration of fecal material after 6 storms had occurred under the climate change. Do you see key change in fecal concentration if you were to use the present day storm? So we'll let you do that before we let Antonio ask his question live. Go ahead, Barbara.
Yeah, thanks so much. I'll actually couple that with the other question, which was about if you want people to empty their latrines formally, you know, how are we going to make people do that? So, and it actually also touches on the previous question that Andrew was answering. So really what our results show is that currently, and something that Dermot said as well, currently we have systems which are not very well managed. So they're very vulnerable to weather events even today. One of the things I get into trouble for saying about sanitation is that actually climate change is sort of the least of our problems. We already have public health challenges because there isn't enough active management of sanitation infrastructure, drainage infrastructure, water supply infrastructure. So I would say that what our results show is that the situation would get much worse as the climate, particularly in East Africa, as the rainfall extremes become more significant. But there's plenty of evidence that we should be actively managing our sanitation systems better even today. And as Dermot says, and I think Andrew's also touched on, that has other implications for resilience to other climate-related health risks. So, you know, we can see in the current COVID climate that if you have a situation where people don't have usable toilets and they have to go to community or shared toilets, it's very hard then to try and limit community person-to-person transmission of an airborne viral infection like COVID. So I think what I take from the work that we've done in Kampala is that we can make this explicit link with improved active management being a climate resilience investment. So it's a good opportunity to link into, for example, climate funding for basic infrastructure. But the overall theme, I think, is about we're not going to solve any of these problems with big, flashy sort of brand new things. I mean, the COVID vaccine is an example of something that has been a real game changer, but nevertheless, we also need to keep going with those basic behavioral interventions. We need people to be doing all of the sort of routine things. The same thing with, you know, if we're going to control dengue, for example, one of the most, as Andrew says, there isn't a cure. So one of the things we have to do is basic vector control. That's just one of the things we have to do. Basic vector control is a local government task. It means local government spending budgets every year, consistently managing things. It's kind of boring stuff. I think one of the biggest challenges we have is to make the sort of boring everyday business of local government, making sure that systems are resilient and well managed, into something that is politically high profile and useful. Sorry, I've gone off on a bit of a tangent, but I think you can pull these threads together quite clearly. And for me, you know, the big puzzle is I mean, in public health, in sanitation, I don't think we're going to be saved with a magic invention. You know, whatever Bill Gates, who's done a lot of funding in our sector, you know, has done some damage, I think, by creating the idea that there will be a magic toilet that will save us all. But actually we need, you know, people like KCCA need to have adequate budgets to do the jobs they have to do. So going back to the original question that I'm answering, can we get people to empty their toilets the day before a storm? Probably not. Could we imagine a situation where Kampala City Council or NWSC, depending on who has the responsibility, can regularly empty latrines and make sure that there aren't large quantities of fecal waste in the environment? Yes, we can. And that's what I think we need to be doing. There you go. Sorry. So I think I've answered my 2 questions, Linda, I think.
Thank you very much, Barbara. Antonius, you can go ahead and unmute yourself and ask your question.
Yes, good afternoon to everyone. Thank you so much for such an inspiring event and for such inspiring presentations and dialogue. Let me first kindly introduce myself. I am a consultant on climate change and health at the African Regional Office of WHO. So I would just firstly kindly like to intervene a bit in the conversation on the vectors and the challenges of vectors in regards to climate change. And I would just very kindly like to add the parameter of urbanization. And I think we should consider the fact that Africa is one of the regions with the highest urbanization trends. And we have a specific phenomenon of a very high development of secondary cities in Africa. Combining that with the spread of vectors and the spread of vector-borne diseases like Chikungunya and dengue, I would like to point out that scientific evidence shows that there is a very strong link of these vectors finding suitable habitats in urban environments, and in combination with increasing temperatures and humidity levels, we should be ready for an increase of such cases in different regions. We have already the example of dengue outbreaks in the Ridoa region in Ethiopia. And just kindly let me also put another parameter, which is the population movements, the migration trends. So I think we have multiple challenges to consider. And also coming back to urbanization, I would just like to give another figure. And we have to consider that also Africa is one of the regions with the highest percentage of slums. And I think that makes it comprehensible to understand how difficult it can be for water and sanitation, and how imperative the need is to design effective policies for sustainable cities. And of course, sanitation and air pollution are 2 issues that can have a clear link also with COVID. So yes, I think all this discussion is really important. We have multiple challenges at hand. We ourselves at the regional office, we make sure to collaborate intensely with countries, and in the same line and agenda that Dr. Diarrheal Campbell presented, to support countries and make sure key policies are in place, and also supporting the process of accessing financing mechanisms to address those challenges. And on the other hand, also to mainstream some key messages, because also apart from all the challenges, we have some very seminal case studies, some very seminal paradigms and examples to be shared on the resilience and the work towards all these challenges of climate change and health in the region. And just to consider that we at the Afro office, we are making sure to collect all those messages and really showcase the importance of implementing such work in global events like the forthcoming COP26. So that is briefly from my side, and over to you. Thank you so much for this discussion. Really appreciate it.
Thank you so much, Antonius. And while we have you, maybe I can ask a quick one to you. You talked about Africa moving into urbanization, but a large population of Africa still doesn't have access to electricity and still use coal and firewood to cook. So there's still the issue of the short-lived climate pollutants and now how it impacts the health of most of the rural population. And so I guess my question is, what are you doing as the Africa office in terms of tackling short-lived climate pollutants and particularly how it impacts on health in Africa?
Thank you so much. That is a very important question. Yes, we are making sure to examine the health co-benefits of various initiatives and interventions that can be identified from reducing, as you said, the indoor air pollution, which is a major issue also for Africa. And yes, the impacts are also mainly related to respiratory diseases. And unfortunately, these are mostly related to children's and women's as being the most vulnerable groups. So yes, we are making sure to coordinate with various countries, especially those countries which seem to be, let's say, in the red zone of indoor air pollution, of some novel technologies and some novel techniques, and for assessing through the use of various tools that we now have in place as an overall mechanism in WHO. So as a first step, we are making sure to monitor and really design in collaboration with countries and ministries of health towards the adoption of new technologies. And of course, in this respect, we are encouraging and we are trying to integrate also a multilateral collaboration with the ministries of environment in different countries to study and monitor also whether the reduction of air pollution has been in the top agenda of the country's national determined contributions to climate change mitigation. So I hope I somehow cover your question. Please.
Yes, you did.
Yeah.
Thank you very much. I guess my next question can then go to Diarrheal, where you talked about the limited funding for climate change and health. And the question is, with what the world has observed with the impact of public health or a public health crisis on basically everything and how it can bring everything crashing down. Do you see a change in funding then coming into the possible outbreaks that could come up in the future in terms of climate change health? So do you see that changing in terms of funding for climate change and health and the health sector?
Well, I have to say, I haven't seen it change yet. I mean, I think it should change. I think there's a couple of parts to that. One is that we tend to look at the multilateral climate finance mechanisms. We look at the Paris Agreement and we look at the Green Climate Fund, which is set up as the main financial mechanism, which is supposed to support countries to mitigate and adapt, particularly low and middle income countries. And adaptation and resilience should be about half of what they support. At the moment, adaptation and resilience is much less than half of what they support. And as I say, even though health and well-being is identified as a priority, the GCF has never funded a health project or a project with the primary aim of protecting human health. And the situation is slightly better with the Global Environmental Facility, but still very little funding to health. And I think there are a couple of reasons for that. One is probably the most important one is that the join between the health agencies, the health ministries, and the climate and environment ministries or climate actors at the national level is not as strong as it should be. So that the people responsible for identifying the priorities and requesting funding from the GCF or GF or others tend to sit in those in environmental climate ministry, sometimes finance, and health is often not at the table articulating what can be done in terms of protecting health from climate change and making sure they're represented. I have to say, and this is a sort of an admission from the health side, it's often not necessarily the fault or only the fault of the environment and climate ministries. Health also needs to actively come forward, and agencies like WHO need to give them the evidence and the arguments and support them to show how they can come forward. But that is a problem that we know we always have a problem working across institutional barriers. I think also we also know that the environment sector tends to be very underfunded. It's usually a much smaller ministry than Ministry of Health. So even though the health ministry and health sector has massive problems, they also have, they are a bigger sector. They tend to have more resources than Ministries of Environment. They do have partners like the Gates Foundation who are supporting parts of their work. So it's not necessarily easy for Ministries of Environment and Climate Change to invite in health and say, come and take a share of the money that that we may be able to access. But more should be done in that area. There should be more support coming to health. That's one part of the issue. The second part is to appreciate that it shouldn't all just be about the donor financing. It shouldn't all just be about the climate finance. If we look at the total amount of money that's been committed to the Green Climate Fund over the 5-6 years it's been in operation, I think the total amount is something like $20 billion. It's a lot of money, but it's absolutely nothing compared to the investments that countries are making in responding to COVID, or even the core investments in ministries of health and so on. So we should be thinking at least as much about having an influence on the overall national development plan, the overall investment plans, as we are about getting some projects from the Green Climate Fund or others. Both need to happen, but we shouldn't lose sight of the big picture. And that is one of the lessons that we've taken from COVID-19. That I don't think, just over a year ago, we would never have thought that countries would close down their economies or put a massive constraints on their economies because of a health problem. That's never happened before. And it's only through that that people have realized just how important health actually is to people, that the populations would not tolerate, don't tolerate a new threat which will come and kill thousands or hundreds of thousands of people. They do want strong measures put into place. So there is a power in understanding that societies are willing to make investments or sacrifices to protect health, but there are in fact investments and sacrifices that should have been made years ago in clean energy systems or in water and sanitation and so on, that actually kill more people than COVID kills. So COVID should be a reminder to us also to do the homework and to make the core investments that should have gone into basic public health infrastructure and so on. But I have to say, I think there has been an increased movement and awareness, but to be honest, we haven't seen it play through in the way it should play through in terms of actually changing in investment behavior. But yeah, these things do take time, and they will only happen if we continue to push.
Thank you very much. We still have a number of questions, but because of time, I think we'll just answer them in the chat. So what I'd like to do is, yes, Andrew.
Just to follow up on that, first of all, it's a pleasure indeed to see Dami. That can pass. We come along with him. I used to visit him at the London School of Tropical Medicine. We used to work together in IPCC. We co-authored books with him. He's a guy who's made a massive contribution to climate change and health. It's just to see him sitting at WHO. But just to add to the local experience in this matter of funding and the link between climate and health, here in Kenya, and not just Kenya, in the region, we had, the fossil fuel industry was not just going to sit and accept that they are responsible for climate change. So they put in place mechanisms to disrupt this linkage. And they supported some very well-known individuals, experts, health experts, lawyers, politicians, to come and say, no, 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 there's very small evidence. In fact, they will not say there is no evidence. They used to say there is a very small evidence that is not reliable. We cannot change policy based on this sort of evidence. So we fought battles at IPCC looking for the best evidence, multi-source, not just health, looking at other sectors, agriculture, water sectors, which were being impacted. And so we packaged this knowledge together and told these guys, look, this is indisputable. It's not just us. So in Kenya, we had a whole group of people who said, no, 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 no. It's not climate change. It's drug resistance. Forget about climate change. It's not the driver. And this argument took a long time. And it sounded a bit convenient for the Minister of Health to go by this statement. So even when we had clear evidence that epidemics were because of climate change, they still said, well, but we need good drugs. Because at the end of the day, all we can do is treat those. So it's a bit complicated. And I don't know what it'll take for people to change their minds and accept that climate change is a serious drug. Okay, yes, we agree. Drug resistance is very serious. But equally, we have to accept that the major generator of the disease is climate change. Drugs only fail to cure what has happened. But the main driver, the primary driver, is climate change, particularly when it comes to epidemics. Okay, endemic diseases, that's okay. But when it comes to large-scale epidemics, it's climate change. Thanks.
Thank you, Andrew. And I guess I'll give all of you a few minutes to give your parting shot, to give us a quote that you'd like to leave us with as we wind up. And maybe, Andrew, since we have you, we can start with you. What would you think our take home should be? Or what advice do you give us, leave us with?
Right now, let me see, Linda. Several years ago, we had a project called the IAC project, Assessment of the Impacts of Climate Change, which we did. In fact, your dad was one of us. Then from there, we moved on to a CCA project. Again, I worked with your dad on that one. That was a very big project. It covered the whole of Africa. And we're trying to look into every sector and see about impacts and adaptation options. Now, there are a couple of other projects. Now, after all that, we are now looking into, we are reflecting and asking the question, how are institutions in Africa coping? Because it's not people in the streets who are going through. Some of this, like health, there's what is called autonomous adaptation to individuals, but there's also institutional adaptation. Health is provided by the health institutions. So we are asking, what are the vulnerabilities of those institutions and what can be done to improve them? So right now we're in the process of doing a major review on that area. Previous to that, we had done a review on policy in the East African region, that there was no policy on climate change and health. Now it is there. But then there's a gap between policy and implementation. We have a policy, but there's no implementation yet. And then, traditionally, we used to go to the so-called development partners and say, our budget is limited by so much. Can you assist us? Now, the trouble is the development partners, which is Europe, UK, US, have their own disasters. You look at the US, serious disasters. So they don't have that spare money to look after us. So it is up to us. It's our governments which have to wake up and address this issue of climate change.
Thank you very much. That's a very strong point in terms of the need for government to begin to prioritize and put their money where their mouth is in terms of climate change and responding to climate change and health issues. Thank you very much, Dr. Giffecko. Barbara, final parting words?
So I'm going to try and take your advice from the beginning and think of something positive to say. And I think one of the really positive things is that Africa is a region where I have not met anyone, I mean, I'm sure there's odd people, but basically everybody knows that the climate is changing. People have an intense understanding of this shift. I sat in a tiny room in a very low income informal area in Kisumu and listened to some really eloquent descriptions of people's lives and how they've changed over 40 years. You know, people talking about the fact that they used to go running in the early morning and they would always wear a sweater, and now, you know, for 10 years they haven't needed to wear a sweater. So these kind of real close understanding that people have. So the positive thing I would say is that if we can provide people, particularly local governments, district health officers, health outreach officers, all of those types of people with concrete practical things they can do, I think there'll be a lot of support in Africa for those types of things. You know, if we start to talk about things that people need to do in order to make the community more resilient, provided we're not just putting the whole burden onto people and expecting them to organize themselves and spend their own money doing all of it. So there's a balance between the public arena and the private, but I think the support from the population for politicians and for local government administrators who are brave enough to really try and get organized around being more resilient is really good. So that's a really positive thing. The more challenging question is that a lot of what we're talking about, and Andrew's also touched on it here, is this problem of we need to address some things which are deeply unfashionable and deeply sort of unexciting, as I said before. So finding ways of making sure that there is attention on these, you know, neglected disease groups. I mean, one of the big problems, I think, just going to the dengue question for a moment, is because it's not something that can be cured, it's not something that attracts a lot of research funding. And so we've got to do work to shift towards the idea that preventive, resilient environmental health is a really exciting and fundamental thing that we've all got to invest in. And if we can organize around that idea, I think there's real potential, particularly in Africa, as I say, because of this really, you know, deep understanding that I think most people have. And I say that as coming from the UK, where there's a lot of climate skepticism since, but I don't see that in Africa. So it's a really positive story. Thanks, Linda.
Thank you very much, Barbara. To Dr. Diarmid, the final words go to you.
Thanks very much. Yeah, no, I'd in fact like to follow on from some of the thoughts that have already been developed on this, on the importance of just bringing this back to practical interventions that will improve people's lives. I would say, irrespective of climate change, it's more than that. We do need to take account of climate change, but also back to Andrew's point about, you know, some of the earliest discussions around climate change and health were around vector-borne disease in East Africa, and they were, I would say, really unproductive. There was a very polarized debate about whether it was climate change causing an upswing in malaria in the East African highlands, or whether it was other things. And I would say that it became as I say, very polarized, to some extent sort of co-opted into the big discussions about climate change and the political polarization around that. And I would say that sort of polluted that area of work for quite a long period of time. Whereas I think now we know the picture that climate change does have a role in that. Other things have a role as well. And you don't have to set these things up as either or and argue about what the problem is. Because if we had started off by saying, okay, we think there is an influence, what do we need to do about that? Well, we need better rollout of the basic interventions against malaria. And it would be a good idea if we made better use of meteorological information to do risk maps and surveillance systems. Everybody would agree with that, even in the absence of discussing the extent to which it's climate change versus other things. So the extent to which we can go to decision makers or the community and say, we know there are challenges around malaria control, around sanitation and so on. It's true that climate change will probably make these worse. We should be trying to mobilize additional support to help you with your problems today. And by the way, that will also increase your resilience to climate change. So the more that we're able to make this a practical, positive agenda, the better. And I think that's also that even goes for things like energy choices as well. It shouldn't be a case of saying, well, Kenya has to reduce its greenhouse gas emissions because it's a relatively low contributor at the global stage, but supplying clean energy to the Kenyan population or the Ethiopian population is a really, really good idea for many reasons, including health. So the more that we're able to turn that into a positive, practical agenda, the better, I think.
Thank you very much. I'd like to give a very special thanks to our distinguished guests for giving us your time and giving us your wisdom and helping us learn from you. I think as ICPAC, we're beginning to see the need to begin to divulge deeper into some of this sector-based discussions, because we recognize that there's a need to begin to even climate-proof the existing systems, even before we talk about what's going to happen in the future. And some of these conversations are a catalyst to people beginning to think, what are the issues? How can we come together? And what can we do with what we have, even before we start thinking about what can we do with the risks we don't even understand. So thank you again for giving us your time. Thank you to the attendees for giving us your time. Thank you, Antonius, for also adding your voice to the conversation. We thank you very much for taking the time to join us on my behalf, on the behalf of the ICPAC director. Thank you to all of you. We'll be having our next discussion on the 28th of April. This one will be focused on the livestock sector. So if you're not subscribed to ICPAC, you can follow us on our Twitter. Our Twitter handle is ICPAC_IGAD, or on Facebook, which is ICPAC IGAD, or on LinkedIn, or check our website closer to the date, and you'll be able to get more information on the next webinar. So to everyone, thank you very much, and we will see you hopefully soon. Thank you.
Thank you.
Thanks, Linda. Great job.